which is rich of various culture. And natural magnificence. Becoming milestone in educating the nation, building persons to be society servants and nation founders. Universitas Pajajaran, or UNPAD, was born due to the initiation of West Java leaders and government support to establish a higher education institution with various disciplines. Launched by President Sukarno on September 11, 1957, today, UNPAD has a large number of institutional achievements. Such as status improvement as the incorporated higher education with A accreditation. This achievement is in line with the commitment of all policymakers in order to accomplish the vision and mission of UNPAD to be excellent university in conducting a world-class education that is able to support the nation's competitiveness through a quality learning process and innovative research. The representative learning facilities and strategic campus in the center of Bandung City, Bandung Regency, and higher education zone in Jatinangor, Sumedang, make UNPAD as an excellent university in conducting education, research, and community services. Through its best programs enabling to fulfill the needs of society. Nowadays, UNPAD has 16 faculties and 1 postgraduate school, totally consisting of 152 study programs. Faculty of Law, Faculty of Economics and Business, Faculty of Medicine, Faculty of Mathematics and Natural Science, Faculty of Agriculture, Faculty of Dentistry, Faculty of Social and Political Sciences, Faculty of Arts, Faculty of Psychology, Faculty of Animal Husbandry, Faculty of Communication, Faculty of Nursing, Faculty of Fishery and Marine, Faculty of Agricultural Industry Engineering, Faculty of Pharmacy, Faculty of Geological Engineering, Postgraduate School. Realizing the importance of learning process, curriculum and learning method are continuously developed in order to adjust the dynamics of stakeholders' needs. Nowadays, UNPAD has used student-centered learning method. That is, learning method focuses on students as the base to actively involve in developing knowledge, skills, attitude and behavior with competence-based curriculum. Supported with professional faculty members and staffs, UNPAD is capable of generating competitive and characterizing graduates. Until now, it has registered 10,000 of students from all over Indonesia and hundreds of international students studying in Universitas Padjadjaran. To optimize the education and learning processes, UNPAD is supported with various representative supporting facilities such as library, Basic Science Service Center, Language Center, e-learning, Teaching Hospital, and Dental Hospital. In addition, UNPAD is also equipped with student dormitory, health facility, sport facility, campus transportation, banking, hall, and entrepreneurship facility. Such various facilities are supported with the utilizing of information technology. Besides supporting the academics quality, Universitas Padjadjaran also fully supports the activity of student character building through some student unit. As a part of society, Universitas Padjadjaran absolutely realizes that its function is limited not only in teaching, but also social and cultural aspects. Some social activities, society empowering, and research implementation have been conducted to give real benefits for all society. Universitas Padjadjaran, straightening and developing together with society. From West Java, for Indonesia, to the world, through SDGs.
Greetings from Transcendent 2021, massive open online course in Cleft Palate held by Faculty of Dentistry, Universitas Padjadjaran Indonesia, collaborating with Smart Trend and also YPPCBL, has been going on for a few weeks. My name is Raisya Aurelia. I'm a student from Faculty of Dentistry, Universitas Padjadjaran, Indonesia. I see that we came from different countries, so I think it's appropriate to say good morning, good afternoon, good evening to everyone here. Greetings to Prof. Albert Paintsil, sorry for if there is mispronunciation, a plastic surgeon and senior lecturer from University of Ghana, and consultant plastic surgeon at Korle Bu Teaching Hospital. Thank you for being here. It's been an honor, a pleasure, and we really appreciate your presence here. Hello, Prof.
Hello.
Professor, would you like to show your face for a second and say hi to our participants here?
Hi, everybody.
Hi.
Hi, Professor.
How are you, Professor?
So as hostess said, I also say good morning, good afternoon, good evening, depending on where you are and which is appropriate for you. I'm happy to be part of this morning's program.
Okay.
Or to be
Yes.
Yeah.
Okay, thank you for giving your time here. Hope you are doing well and also stay healthy. We also have Dr. Dani Rizali Firman, Master of Science, a lecturer, and he is also the manager of academic programs and students affairs of Faculty of Dentistry, Universitas Padjadjaran, Indonesia, as our moderator. Thank you so much, Doc, for being here.
Thank you so much as well. Hello, everybody. Good morning, good afternoon, and also good evening as well.
Also, we don't forget to greet all of the participants here. We would like to thank you for participating in this course and also thank you for attending this live discussion session. So, Professor, today is our live discussion in the third week. This week, we are learning about bilateral cleft lip repair, unilateral cleft lip repair, cleft palate repair, and palate repair. So today we are going to discuss about cleft palate repair with Professor Albert Paintsil. This live discussion will be separated into two sessions based on the topic. So first, Professor Albert Paintsil will answer the question that have been filled out by the participants in the MOOC website, and the question will be presented on the screen. After that, the participants will also have the opportunity to ask questions directly to the professor or through the chat section. The participants can write down the question, their name, and also where they are coming from. So, Professor, for your information, all the participants here have already watched your lecture video about the related topic. And I think not everyone cannot make it into today's live discussion, but I'm pretty sure that all other 300 participants that have registered into our courses have watched your lecture video as well.
Okay.
Yes, so now I would like to give the spotlight to Dr. Dani Rizali Firman as our moderator and also Professor Albert Paintsil as our speaker. So Dr. Dani Rizali Firman, you may start the first session and lead to today's live discussion. Thank you so much. We can move on to the first session.
Okay, thank you, Raisa. Okay, everybody. Once again, good morning, good afternoon, and good evening. It's a pleasure for me to join this session. This massive open online course was organized by the Faculty of Dentistry, Universitas Padjadjaran. And this is such an honor for us for having Professor Albert Paintsil. I'm sorry for mispronunciation of your name if I just misspell or mispronounce your name. Okay.
You're doing very well. It's
okay. Thank you very much, Professor. At this first questions, I would like to read for you and the audience as well. Okay, this is coming from Siva Biandra. In the lecture, the color of blood from incision is something that we need to pay attention to. Could you explain more about paying attention of the color of the blood? What color is classified as peculiar, and what should we do if the color is not as we expected? Yes, that is the first questions. You may try to explain or answer the question. Thank you.
Thank you very much for this question. For the repair of cleft palate, one very crucial maneuver is to put in your gag or the instrument that will open up the oral cavity so that you can see the defects and repair it. And that gag or that instrument could compress your endotracheal tube, in which case oxygen getting to the child's lungs and therefore into circulation would be reduced. So if that is happening, then when you make your first incision, you will realize that the color of the blood will not be bright red, but it will be darker, more of venous blood instead of arterial blood, which is bright and nice. So before you even make the incision, I said also in the lecture that you have to look at the endotracheal tube and see a mist or a vapor as the child ventilates. That shows that the airway is okay. And you also ask the anesthetist about airway pressure, if the airway pressure is okay. So having done this, if you make your incision and it's dark, then it means you tell the anesthetist, and then together you will look at your endotracheal tube to be sure it's in the right place and it's also not compressed by your gag or the instrument for opening the oral cavity. Once you check and everything is fine, probably the anesthetist may increase oxygen or whatever, but that color must change before you proceed with the surgery. I hope this has answered the question.
Okay, Thank you very much. I think this is really easy to understand that the color, which is the darker blood, become an indicator, an essential indicator. So we could, anticipate, or we could do something that need to be done. Thank you, Professor. Can we proceed to the next question, Professor?
Yes, please.
Okay, number 2, from Maulida. This is from Universitas Pajajaran, Indonesia. As a professional, what is the greatest obstacle in cleft palate repair that you have faced before?
Right. As a professional, I think that well, I will not say obstacle. When you say obstacle, it sounds like because of that issue, you could not do your repair.
Okay.
And I think that by and large,
Challenge, probably
yeah,
challenge.
challenge, exactly.
Okay.
And the challenge, the greatest challenge has been clefts that are very wide.
Mm-hmm.
So you look inside and you look at the cleft, and you can use your calipers to measure the distance between the sides of your cleft. And sometimes if it's around 2 centimeters, trying to bring tissue from the side to the middle to close your defect can be very challenging. And for me, that is it. But when you come across such challenges, there are other procedures you can do, like taking tissue from the side of the mouth. I mean, intraoral, you can raise extra tissue from there. Sometimes people use tongue. I mean, there are other things you can do. But for the beginner, I think that we'll restrict ourselves to clefts that are not too wide, so that you can achieve your closure. That would be my challenge, really.
Okay, so it depends on the severity or the width of the cleft that
The
you.
wideness of the cleft. Yes,
Okay.
you are right.
Okay. Thank you, Professor. Let's proceed to the next questions, please. How to assess a successful, good repair of the muscle, and how to overcome failure in repairing the muscle, Professor?
Okay, thank you.
From Gretanza. Okay, please.
Yes. Gretanza, thank you for a wonderful question. During the lecture, I said once you raise your mucoperiosteal flap, you will see the muscle attached to the nasal mucosa. So to assess that you have a good repair on the table or during the time of surgery is when you have been able to get the muscles from both sides and bring them across in the midline. If you are not able to do that on the table, then you cannot be sure of a good repair. But the success of your repair will really depend on speech afterwards. So having repaired your cleft, when everything has healed, you send your patient to the speech and language pathologist. They will assess the speech and they will tell you whether your speech has been or your repair has been good. So the muscle is moving well, and so speech is excellent or otherwise. Now, if the speech and language pathologist tells us, or the speech therapist tells us that the speech of this child is not good, then we'll have to analyze why there is velopharyngeal incompetency or insufficiency. And then this child may have only speech therapy repair, or might have to come back to surgery for re-repair or do other procedures such as pharyngeal flap to augment your repair to get a good speech. So on the table, let me just summarize. On the table is your ability to see the muscles on both sides, bring together in the midline, and suture together. That feeling, you have to get to do it. Then later on is the assessment of the speech of the patient. Thank you.
Okay. Thank you, Professor. So the function of the muscle will lead to a better speech
Yes.
in the patient. So that is one important indicator for this as a good repair
Yeah.
of the operation. Okay, thank you, Professor. Let's proceed to another questions, please. Okay, this is for from Gretansa as well. How long does fistula complication usually appear? Okay.
Okay. Good question. Once you've done your repair, as I said in the lecture, to prevent or to reduce the incidence of fistula formation, you have to make sure your repair is without tension, especially at the junction between the soft and hard palate. But if there is an issue, usually within 2 weeks, you see the fistula appear. And it's usually around this area of the junction between hard and soft palate. But once you see it that early, post-op, don't be in a rush to repair it. Don't be in a rush to repair it. One, the tissues there will be dematous, swollen, will not be pliable, meaning when you try to move it in another surgery, it won't come. So you wait, and usually I will wait for about 6 months. What the 6 months will do is that healing around will be complete, and you'll be surprised to see that your fistula, which maybe was about 1 centimeter, will be reduced to about 0.5 centimeter, and the tissues will be pliable for repair. So fistula may appear up to 2 weeks after repair, but don't be in a hurry to go back and repair. Give yourself at least 6 months. That is what I do in my practice.
Okay.
Thank you.
Okay, thank you for the answer, Professor. So there is some variation. It depends on so many factors, right?
Yes.
From 2 weeks until 6 months. That is the duration that we could expect for the result. Okay. Okay. The next questions, please. Okay, this is from Faras Reza. The question is, for the case that you mentioned in the lecture, why did you choose to use the von Langenbeck technique instead of the Furlow double opposing Z-plasty technique? Okay, it's a bit technical, okay. It's all right.
Yes, it's a big technical. So von Langenbeck is the repair where you use the bipedical technique from sides. And then the fellows is where you do Zs on either side. So during my lecture, I did talk about Z plastics, but I just mentioned it in passing. I also advise that as a trainee, you must see what you can do, learn all the techniques, and be prepared to use what is good in your hands. So my simple question is that for the case that I use von Langenbeck, somebody could have used the opposing Z plastic, and that person would not have been wrong. But for me, I felt that von Langenbeck would work, and it did work. So learn the techniques, see which one works best in your hands. Yeah. It's for the sake of the patient to get a good repair done, good speech. And maybe depending on what you want or what you like, but that is what I would say.
Okay.
Is that clear enough, Dani?
Yeah. I think it also depends on the skill of the operator, right?
Exactly.
So
exactly.
Yeah,
exactly.
There's sometimes we could just not compare between two technique that easily, because there are so many other factors such as the operator skill as well. But that is something that we could understand. Thank you, Professor. Okay, so we could proceed to the next questions, please.
Doctor and Professor, I think that was the last question.
The last questions. Okay. So after the question and answer from the discussion forum, we may proceed to our second steps. So all the audience in this Zoom meeting will have a chance to directly ask the professor. You could just ask the question directly to the professor, or you could put it on the chat or message. Please, this is such an such a good opportunity to have a direct interaction with the professor. Let's see. So how many case, let's say from day-to-day basis, professor, that you handle? Is it weekly, or you could count as a day-to-day operation in Ghana?
I in the center where I work, we have 3 teams, and each team will do 1 or 2 a week.
Okay.
So in a year we do about 6. Sorry, in a week we'll
in a
do
week.
4 and 6. Yeah, 3 and 6.
Okay.
And then occasionally we will, for example, tomorrow we have about 10 children we have brought together, and we'll do all 10 tomorrow. And so for the, it depends on the patients when they come in and when they are ready for the surgery. But once, 1 or twice for me personally, every week on my list, every week.
Okay. That's quite a lot, and then is there any trainee that help with the procedures?
Oh yes, we have trainees working with us in the center in Korle Bu.
Is there any students from overseas as well?
Well, overseas, outside Ghana, yes.
As outside Ghana, yes.
Outside Ghana.
Okay. Is there any from
Africa,
Asia as well? Okay, South Africa.
No, just in Africa, so West Africa.
Okay.
We have the French speakers, we have the English speakers.
Okay.
It's most likely to be an English-speaking person because of language. Yeah.
So I'm afraid we still haven't got any question from the audience or the participants. Is there something else that you would like to emphasize from your previous video, Professor?
My emphasis would be the first question asked about the blood. Always make sure your communication with your anesthetist is very good. For the sake of the patient, you always make sure that the anesthetist is telling you that the airway pressure, because the gag could compress your tube. In other places, they have tubes that are reinforced, and they have other forms of gags that is used. But for me, you as a surgeon must ensure that it's okay. And then my second point would be your comment on the using one method or the other. So there's no point in wanting to do something you are not conversant with and you are not good at. You end up with problems in that patient. And usually you may have to send the patient to another person to solve that problem. And I don't think it's good. So for panelists or for participants here, especially those of us who are beginning our training, let us concentrate. You are with your boss. He or she is the one teaching you. He's teaching you the basics. He's teaching you how to handle tissues. He's teaching you how to make decisions. Pay attention to those. Once he has seen you through your training and you are okay, then you can, on your own, decide to do other things. Of course, with safety in mind, that you make sure whatever you decide to do, your patient will not have any problems.
Okay.
Thank you.
Thank you, Professor. So we already have two questions from the audience. The first one is from Adira. The question is, what is the most common complication on cleft repair, especially for the adult patient? So not in children. Okay.
Okay. Yeah. For the adults, I've realized that it's bleeding. Bleeding is the commonest that I have come across. Because this once you raise your flaps, because it's an adult, the periosteum that is attached to the mucosa as will have made some depression or gotten into the bone of the hard palate. And these are usually vascularized. So once you pull them or you raise your flap, you may experience some bleeding, which will stop. But post-op, if pain relief or if the patient is a bit agitated or anything that will make the blood pressure go up, that patient may bleed. So that is the commonest, most common or the commonest complication. Then of course, the others like infection, fistula, and so on.
Okay. Thank you, Professor Adira. Hopefully, your question already being answered from the professor. Okay,
Yes,
the second. Okay, thank you, Adira. The second questions from the participants is from Alia. She said that she learned from the lecture that the ideal time for the cleft repair is range from 9 until 18 months. Why is that?
Okay. You know, I have always looked at the use of the guard to open the oral cavity and the access you can get there to do your dissection and do your repair and suturing. So I think at this age, at least 9 months, the child, if he had lip, you have repaired the lip already, he's been able to eat, to put on weight. When you go in, you can see the tissues clearer, especially the muscles, so that you can do a better repair. And then we say 18 months for the purposes of speech. Beyond 18 months, the child will now learn to talk without a repaired palate, which gives the wrong speech. And when you repair that later, you realize that the speech may never be correct. So in adults, if the cleft of the palate is not repaired as when the person is a child, when the person becomes an adult and you repair, speech is not good. So this timing is for the child to put on weight, to look okay, so that you can see your muscles well. And then the second reason is speech. You want to do it before speech begins, formal speech begins.
Okay. Okay, thank you once again, Professor. So we still haven't got any more questions. Thank you for your explanation, says by Alia. Is there any other participant who would like to, ask directly to the professor?
Sir, I think that was the last question from
I think that
Alia.
was the last question. Okay. Okay, Professor, probably if you want to wrap up our session, probably you could just make some conclusion. I know you already explained about the emphasis of your previous lecture, but probably just to wrap up this session. Okay, thank you.
So to wrap up, children and their parents, the children may not be aware. In fact, they will not be aware, but the parents are in great distress about this birth defect or this congenital problem. Okay. And you as a cleft surgeon, you have the ability and opportunity to give them that happiness or that satisfaction. And I think that if you learn to do this and do it well, then you give those patients and those families, you give them the peace of mind. The second one is that in wrapping up, we talked about very wide or the challenges in cleft. If you work in a center with other colleagues or on your own, if there's somebody closer by who has more experience, when you see difficult ones, be bold enough to say, I will send this one to somebody else to do it, and not struggle to do something that will not be the best. And once you learn how to do this very well, it's a delight to operate on the cleft child and see the results. Makes you very happy as well as your clients, and you will for a long time continue to give that service to others. Thank you very much for having me. I've enjoyed this session, and I wish all the participants and also other faculty, I wish you all very well in your endeavors, and pray that all will be well. Thank you.
Thank you, Professor. We also really enjoy by getting all the explanation from you directly. And then one thing that I could get from you as a wrap up, we as a trainee or a doctor, later on we have a big opportunity to create a brighter future for the patient. Okay, that is something that I think really good motivation for us to learn something much better. In this case is the cleft and palate topics. Thank you once again, Professor. I will give the opportunity to close the session to Raisa.
Thank you, Dr. Dani. Thank you, Professor Albert. We have reached the end of today's live discussion. It was a great opportunity for all of us hearing the valuable knowledge from Professor Albert Paintsil on this special occasion. And thank you for Dr. Dani Rizali Firman for moderating this session. Before we end today's session, maybe we can take a picture. So for all the participants here, please turn on the camera, and then I will have to count 1, 2, 3, and the committee will screenshot the Zoom meeting. Okay.
Put a big smile.
Show your big smile, and then I think everyone is ready right now. Okay, I will start counting. 1, 2, 3, cheese.
Yes.
1, 2, 3, cheese.
Yes.
1, 2, 3, cheese.
Cheese.
Okay, maybe that's it for today. Thank you for Professor, and also thank you for Dr. Dani.
Okay.
In this hard times of pandemic, we can still find the bright side. I believe that this will be such an inspiration for all of us to learn cleft lip and palate more and more, even further, to implement the best treatment to our cleft patients in the future. Thank you so much for everyone. Goodbye. Stay healthy.
Thank you. Have a good day, Professor.